Welcome once again to Physiotherapy Hour with Dr. Thursday. And today we are going to be looking at some topics that concern children. We'll start with Erbs Palsy. What is Erbs Palsy? Erbs Palsy is a paralysis of the upper limb affecting primarily the upper trunk of the brachial plexus. I'm going to explain what the brachial plexus is in a moment. But Erbs Palsy actually, you will see some children that are born and then you find out that their hands, maybe one hand or the two hands, they are not able to lift it. They are not able to use it. The hand is paralyzed. It's actually most times due to injury at birth. It is not a congenital malformation. It is due to traumatic injury, and I'm going to be explaining briefly. So this results in weakness or paralysis of the muscles of the shoulder down to the hand. And of course, because these muscles are the things that, the structures that carry out function. Actually, movement is carried out by contraction of the muscle fibers. So when the muscles are not able to contract, the hand is not able to move because it's paralyzed. So you have paralysis of the upper limb. Now, what is brachial plexus? Brachial plexus is a network of nerves that actually takes origin or its roots from the cervical region. When we say cervical, we mean the neck region, and it takes origin from the cervical root 5, that is C5, what we call C5, up to T2. So you have C5, C6, C7, C8, T1, and then T2. All these things are used to describe the cervical, the vertebral region. So C means cervical, T means thoracic. So from C5 to T2, the nerves originate from that place and then runs through the shoulder to the axilla and then now take peripherally. So this brachial plexus is actually divided into the diagram I have here on the board. You can take a look at it. The brachial plexus is divided into, you can see it, roots, trunk, division, and cord. So from the root, you have C5 to T2, or some people start at T1, but it takes combination from T2. And then from the trunks, you have the upper, middle, and lower trunk. And then you have the divisions, and then you have the cord, lateral, posterior, and medial. And from here, they take branches to the various parts of the muscles of the upper limb. If you look at that diagram very well, you see the nerves running through that is the axillary region, that's armpit. You see them there, they are very more prominent there. And there are now branches to supply the muscles of the upper limb. What's the upper limb? We're talking of the hand. The hand. So the hand anatomically actually means here. But when we say upper limb, clinically, we're talking about the whole hand. So the muscles that supply the hand takes innervation from this root. So when there's any injury affecting the brachial plexus, either at the root level or otherwise, you find presentations of paralysis according to the severity of the injury. So how does Erbs Palsy present? Clinically, the presentation of Erbs Palsy depends on the severity. But let me make a point here. There is a general injury that we call injury to the brachial plexus. It could result in different types of syndrome, which we call paralysis. There is the Erbs Palsy. There's also another type we call complete syndrome. There is the complete paralysis. So depending on the present, today we are looking just at Erbs Palsy. How does Erbs Palsy present? The Erbs Palsy presents in what anatomically, clinically is referred to as policeman or waiter's stick position. That means the hand is like this. If you know how police people usually collect money those days, not now, that they are now so brave, so open to collect it. In those days, they put their hand at the back and then you give them the money. That is the position of, you can take a look at this diagram again, at the diagram on the board. Take a look at that little boy. You see the hand. You see the way the hand is behind. That's what we call police or waiter stick position. Please focus more on that. So you can see that. So what you have is there is an internal rotation in the shoulder, because the muscle that externally rotates the shoulder is paralyzed. Then there is an extension of the forearm, okay, instead of flexion of the forearm. So the hand is like this because the flexor compartment is affected. Then you will now see pronation also of the forearm. When I say pronation, this is pronation, this is supination. So there is pronation of the forearm. And then the wrist is now flexed. So you now have that typical deformity. Okay? Now, what to look at? How do we treat this? Is it treatable? Yes. And the treatment, the mainstay of management is actually physiotherapy. The injury is traumatic. How does it occur? It occurs usually at birth. So during delivery, especially when there's an assisted delivery, where maybe the nurse or midwife or maybe the gynecologist helps to assist the baby to come out, and they pull on the shoulder or on the head. Now, what we call downward traction of the shoulder, when there's a forceful pull, it results in traction of this nerve, stretch, and then the injury occurs, the injury results. So this injury can also occur in the adults. For example, most of those adults that works in the mills, the grinding machines sometimes could forcefully abduct their hands and cause this injury. But we're talking of this injury occurring in children. And of recent, we have found that there is a high incidence, high prevalence of this condition. And actually, that's one of the reasons we are doing this lecture, to also enlighten the gynecologists and the midwives, okay, to apply caution when they're assisting these women, because we are noticing a high prevalence of this condition. So the question is this condition treatable? Is there a cure? Like I said, is an injury. Now, if it is curable or not actually depends on the severity. In some cases, it could just be mild. So when it is mild, within a few physiotherapy treatments, there could be total resolution. In fact, in some cases, even without treatment, the hand could be resolved. The paralysis could be reversed and activity returns. And so the baby can, especially when it's in shock. So, but that is in very rare cases. In other cases, if the severity is maybe mild, let's say it is mild, okay, within a few physiotherapy sections, it could be resolved. And in some severe cases, it may not be resolved totally. And in those cases, they may need surgery. So what do physiotherapists do? Number one, if the presentation is early, you want to prevent muscle atrophy, that's disuse atrophy, or atrophy due to the paralysis itself. What do we mean by atrophy? Degeneration of the muscle fibers, or in simple terms, dying of the muscle fibers. You see that the muscles begin to shrink, it begins to get smaller. And of course, if treatment is not done, the hand will not even grow like the other hand. You see one hand bigger, much bigger. The hand continues to shrink and reduce. So we want to prevent that scenario. We want to also build the muscle power and of course bulk. As the muscle power is being built, the muscle bulk is also developing. And that is in situations where the presentation may not be early enough. In some cases, even when the presentation is early enough, you may not be able to prevent absolutely atrophy, okay, because the treatment is not 24 hours. So because of logistics here and there, the patient may not have a complete, adequate treatment that will prevent total atrophy. So we want to build up the muscles that are atrophied. We want to build up the muscle power. We want to restore function. And how do we do this? We use various techniques and modalities. Okay, we use various forms of electrical stimulation, electrical nerve stimulation. We use various forms of therapeutic chemotherapy modalities that will improve healing and nerve recovery. Okay, we also want to apply certain soft tissue mobilization and positioning. But the bottom line is that the treatment is not stereotype, it's a dynamic treatment. So a qualified physiotherapist is actually, because the presentation of one person may be different from another person. So the treatment is individualized. So you need a qualified physiotherapist to be able to make an assessment and then implement proper treatment plan, okay, that will see to the resolution of this. By and large, if after a year or so and you are not able to get a very good recovery or total recovery, it is possible that nerve transplants may be done. It means probably the damage to the nerve has become irreversible. And so in most cases, nerve transplant, in some cases, very rare cases though, nerve transplants are done. And, but even at that, physiotherapy remains the mainstay of this management. Please, if you have questions as usual, drop in the comment section. Thank you.